My thanks to the chairman of the session for the kind words of introduction, and of course, thank you for the invitation to the president of this conference, Dr. Iakovou. Now, my intention is to take it over to the mitral valve, and I hope that soon we will not be talking about minimal invasive mitral valve techniques anymore, and that they will be commonplace for everybody. And with that, I would like to de-emphasize my presentation from the surgeon and the technique and think a bit about patient journey. I think this is what we surgeons have been doing wrong over the decades, putting too much emphasis on how we cut, how big is the cut, whether we use retractor or a camera or robot and things like that. So I don't want to get too much into hyperspace theory, but minimal invasive is not equal minimal invasive. So there are different kinds of minimal invasive mitral valve procedures. There is the manual where you make a small cut and you use your hands and your eyes looking inside with special light sources to do the mitral valve repair. There is the endoscopic one whereby you mostly use the camera and look at a screen when you do the same. There is the robotic one, where you use robotic arms. Robotic, by the way, I consider it a euphemism because it's not a real robot. You don't program it and it can execute the surgery itself. It's just a telemanipulation system. And then, of course, we have new upcoming hybrid procedures, which will be very critical for all of our future, where cardiologists and heart surgeons will be addressing complex heart problems in 2 or 1 single stage. These are my disclosures. Possible minimal invasive cardiac surgery procedures include all of this. So minimal invasive, not just mitral, even though mitral seems to be the staple of minimal invasive heart surgery. All these procedures are possible in a minimal invasive fashion and combinations of those. Now, when it comes to the mitral valve repair, minimal invasively, mitral valve surgery, minimal invasively, or altogether, I would say, mitral valve repair, we would consider those people here to be the pantheon of mitral valve repair. Up front, Professor Alain Carpentier, who in 1983 presented the French correction in the AATS conference and showed his early experience with novel techniques of repair of the mitral valve and revolutionized the field. And to this day, many of us, whether we do it open or minimally invasively, we follow the Carpentier technique, the so-called French corrections, added by or contributed by all the other eminences of mitral valve repair around here. So these are some of the techniques, and I'm not going to go into the very detail because they may be just interesting for the surgeons. We use cords. We try to respect the tissue and not resect it. Nowadays, we use special loops and so on and so forth. Existing methods include artificial cords, as these little green cords display there. There may be single cords, double cords, multiple cords, and so on and so forth. We may have to do a triangular resection, quadrangular resections to get rid of excessive tissue and tissue motion. We may do sliding or butterfly resections. This is how, more or less, we do mitral valve procedures. In Barlow's, of course, it's a different story. Barlow's is like a chameleon, and it may always deceive you. You may put on 1 cord, 2 cords, 5 cords, 10 cords, do water tests, and think it looks okay, and then you come off pump and the valve is still leaking. So Barlow's is a bit of a special situation. So you may have to do resections, sliding plasties, cleft closures in Barlow's, and so on and so forth. So again, I spoke about the different dimensions of minimal invasive mitral valve surgery. There are indeed benefits with a minimal invasive procedure, which are well known and well published on. Decreased risk of infection, less blood loss, less trauma, less arrhythmia, less lactate. The last two may be connected to each other. We found in our own data in Singapore in the past that if lactate is too high, the likelihood of arrhythmia is much higher postoperatively. Decreased length of hospital stay, that has an important socio-economical value. Decreased recovery time. the recovery time that we don't see, the one after the discharge from the surgery, from the hospital, is also much better. And it's a great platform for synergy and growth with the cardiologists, because disease comes in a combined fashion nowadays. We have enough patients nowadays who have two stenosis and mitral valve leakage, so to speak, and then the patient insists to have his surgery done minimal invasively, so cardiologists may take care of the coronaries first, and the surgeon completes with a minimal invasive mitral valve repair in all possible combinations. And I do believe that the hybrid platform is the future for all of us. And it gives you a great stage for customization and personalization of the procedure. They call it personalized medicine nowadays. We want to launch the term personalized cardiac surgery, because it's not like black and white 20 years ago. We have all these options we can discuss in the heart team nowadays. In my own practice, an isolated mitral valve, most likely, almost 100%, will be done endoscopically, minimal invasively of some form. Combined procedures, usually a very high number as well. Mitral valve and atrial ablation is also tending to be close to 100%. Bypass surgery, 50 to 60%, and this is because many patients seem to qualify for minimal invasive bypass, but then we discover in the CT scan that they have calcifications, unfavorable anatomy, topography in the chest, and many other reasons, calcified vessels in the periphery, that they don't entirely qualify. And these are data from Singapore. Remember, we have Chinese patients there, much smaller, flatter, big heart, low ejection fraction is not the same, and the coronaries are really lousy. So there are certain situations where we pay particular attention, but I wouldn't recommend a surgeon who is venturing into minimal invasive mitral valve surgery to go into those situations. Try to avoid very flat-chested patients with verticalized hearts in the beginning of your experience. For example, Marfan patients, very picnic habitus with severe obesity and high standing diaphragms, particularly ladies, extremely low ejection fraction, severely impaired right ventricular function, very severe pulmonary hypertension. The new recommendation by ISMIX is 75 millimeters of mercury, inaccessible combined pathology, severely calcified aorta, and severe adhesions. I ask the surgeons who don't want to embrace minimal invasive heart surgery, why not? Are you too old? Are you too scared? Is it the competition who is waiting around the corner to kill you? Is it too difficult? Inertia, comfort zone? And I speak of experience because I'm going around 20 different countries proctoring, and most of the times, you believe it or not, is not the skill. It's the politics and the availability of materials, the support by the system, the CEO, the hospital, and so on and so forth. And this is actually a pity, because this way the young generation never learns, and they get stuck behind old and dinosauric, Jurassic, attitudes. Technical aspects of minimal invasive. Now, in this section, we're going to talk about the setup in the operation theater a bit. Surgeon, assistant. Actually, you need only one assistant for a minimal invasive mitral valve procedure. This is the access, a small cut about 4 to 5 centimeters on the fourth intercostal space, and a few instruments that couldn't interest you less, but the surgeon perhaps. These are the cannulas we're using for femoral cannulation. Some of the clamps we're using. The upper left side shows you the Chitwood clamp, which is the queen of clamps in minimal invasive mitral surgery, I would say. The other ones, we don't use them so often. We use special instruments for retracting and opening the left atrium so that we can see the heart valve. Endoscopic instruments. The access from the side, from the fourth intercostal space, ladies and gentlemen, is the best you can have to catch the mitral valve in a resting, anatomical, and physiological position. This is refuting directly and firmly the surgeons who insist in doing these procedures open. It's a good, well-validated procedure, who allege that the minimal invasive surgeons don't have good visibility of the mitral valve. This is what they are telling the patients so they can keep the patient themselves. Unfortunately, for them, it's not like that. The minimal invasive access gives you a direct view of the mitral valve without retracting the heart, without dislodging the heart, in the sense that you have the leaflets as they are, and when you do water test, you have a much better, in my experience, testability and accessibility of the valve. You see right in the costal space, right into the mitral valve. This is the setup in the operation theater. This is an animation that shows you how we set up. Of course, the incision nowadays is much smaller. The camera comes from the second intercostal space, so down below, different schools, different traditions. Fem-fem cannulation. This is the view looking at the screen and the final result. Now, let's go to the next step. This was the first stage of manual setup. The totally endoscopic and 3D supported systems, the incision becomes smaller because you're using the camera's eyes to look into the left atrium. I tend to use the camera from below, as you see, in the extension of the work port, because it doesn't tangle with my sutures around the valve, and it's the most ergonomic one, I believe. This is how we do it. I mean, in the interest of time, I'll skip. Some new technologies raise the bar for training, but they also make our life easier. For example, endoballoons, where you can clamp the aorta from the groin and instill cardioplegia solution, stop the heart without having to put a clamp around the aorta. This is done in patients with irradiation, patients with severe adhesions, or redos. And in some programs, like in Belgium, in Aalst, it's routine. These are some of the patients, and this is the condition of the patient on the third post-operative day, shortly before going home. This is the usual thing we see in the follow-up clinic, young ladies as well. This is an aortic valve patient on the right side, but you can see that even obese patients may qualify. Ladies with big breasts, they can entirely hide the incision. And then we have two good cases, but this is a bad case. What is a bad case? You see how the heart is verticalized in a Marfanoid patient. When you take this patient on pump from the groin, fem-fem, the heart evacuates, empties, and flips over the other side over the spine. And it's very difficult to reach it and see the mitral valve. There are some tricks to avert it. For example, you continue inflating the left lung. You use retraction stitches. It is possible, but I would say avoid such a patient to do minimal invasively if you are in your first 50 cases. Concomitant pathologies, endocarditis cases, and the importance of simulation and training. So this is a concomitant case where I did an MVR, ASD closure, atrial ablation, and TVR. Sometimes we must use a certain situation as an opportunity. The patient had a flexible 3-centimeter ASD, which I used to enter the left atrium, do whatever I have to do with the mitral valve, the atrial ablation, and then close the ASD and take care of the tricuspid valve. So here you see atrial ablations done minimally invasively, both the bipolar as well as the monopolar part. I'll show you here the next stage now, which is the totally endoscopic transareolar mitral valve repair. In the interest of time, I move forward here.
6 millimeter.
So you make a 60% circumferential incision around the right nipple. You fall right into the fourth intercostal space, and you have a beautiful view using a 3D camera or 2D camera, opening of the pericardium, retraction of the pericardium. I just want to show you the incision eventually here. Okay, the pathology, P2 prolapse. You'll see it in the end. And you proceed from there, entering of the retractor. Here is the setup, briefly, with LV vent, with camera, with left atrial retractor. Here I'm about to implant the ring, and the pink cannula there, shown by the arrow, is the cardioplegia cannula, all through this little transmammillary incision. I'm not going to go into the detail how to take care of a simple P2 repair here, but the usual way, it's about the technique. And in the interest of time, that's basically the ultimate stage, and this is what the patient walks out with. A beautiful cosmetic situation and a very fast recovery. Transareolar or transmammillary mitral valve repair. There are some situations where you should avoid going to the extreme or pushing the envelope. For example, endocarditis. If you're lucky, my friend Mario had a case of endocarditis superimposing a Barlow situation. Thankfully, the endocarditis was healed. He was able to just take care of the Barlows. You see the valve is relatively clean. I think he did a sliding plasty here, evidently. See, he's working on the annulus. then close the clefts, put in his cords, put in some more cords. Again, the Barlos is demanding such complex procedures, but we'll have a solution for that in a little while. I'll show you. Implantation of the ring, addition of another cord, and with a very good result. This is if you are lucky. In this case, I wasn't so lucky, and see the pathology for yourself. It is an 80-plus-year-old patient with severe endocarditis, which was not healed, vegetations everywhere. You see a partially calcified anterior and posterior leaflet. Why I'm showing this case? There is a limit to everything. I wouldn't proceed to do leaflet augmentations and all kinds of experiments in a situation like that, in a badly healed endocarditis, and have the patient come back to me in 3 years' time. Just replace the valve. I had to denude the annulus, though, as you see, because the endocarditis affected the annulus, and I implanted a neo-annulus, a bovine pericardial patch, which is a very strong hold for the new mitral valve prosthesis, which I did next. It holds better than the endocarditis-affected annulus itself. And done. So there is another extreme case of a 51-year-old patient, 38 kilograms, not 31, who came to me as an emergency in the middle of the night, and on top of everything, a decompensated endocarditis, mitral valve regurgitation, Barloid pathology, I would call it, and wanted to have a minimal invasive procedure based on very cahectic, as you see, and this is the X-ray. It's an extreme case, but okay, I thought, let me try, see how far we can go. You see how deep the instruments go, very difficult to access. Anyways, a fully destroyed valve. Let me jump into the pathology. As you can see this massive vegetation here. What to repair on this valve? So they say it's good to know where not to do something, not only when to do something. So I wouldn't repair this valve. So replace and get on with it, walk out the operation theater with impunity. Troubleshooting in minimal invasive mitral valve surgery. Bleeding, conversion, redo MVR, large cavities, femorals that don't work, circumflex artery injury, and the airing problems. Again, there is a solution for every situation. My message here is that if you have bleeding from an area you cannot see on the back of the heart or from the left atrial appendage, let's be decent, convert, and go through a median sternotomy. MIS, it's all about tips and tricks to facilitate complex surgery. Good planning and patient selection is key to success. New technology facilitates new solutions. Combined cases of all sorts are possible. I personally don't favor pushing the envelope where I consider it illogical. And it's good, they say the good surgeon knows how to operate. The better surgeon knows when to operate, and the best surgeon knows when not to operate or do a certain technique. So I want to show you some outcomes because the cardiologists ask, and most of the times we surgeons show how to do it and how great techniques I'm using and all this. We rarely show real data. So I'm showing my data, and you can see pink is minimally invasive and open is blue below. The blue boxes is the optimal Euroscore area. And well, thankfully, we are far left in our program. But you will see that in minimal invasive is no less, is on a non-inferiority basis, it's actually better than open. So you see for yourselves that the data are very, very good. Why I mention that? Because there are still doctors out there, again, for commercial purposes. I'm referring to Singapore, I'm not referring to Greece. So,
what is going to happen? What was in Singapore state there?
Yeah, well, it's very advanced technically, but people tell the patients that minimal invasive is worse than open, and it's unsafe, and it's experimental, and it's new, and it's 30 years out there. So these data speak for themselves. I'm not going to go into the detail. Also, the post-operative complications, the same, very equivalent. New technologies, 3D technology, core knot devices, devices that tie the knots automatically so they save us cross-clamp time. And I developed the Uniport minimal invasive mitral valve surgery where everything can be done with devices you know already from a single port incision without additional ports for the other instruments, using Perclose, for example, and this is the result. You don't see anything. So this, and you can do bypass procedure and so forth. I'm going to close now with the Greek correction. Some call it Singaporean, some Greek. The techniques we're using by Carpentier, They are good, validated, but to me, they are not perfect because they're not standardized. And meaning that, why does it happen that I go in and I may come out with a leak for the P2 prolapse, and Thomas or Greg may come out with an excellent result. And we all both know the same techniques, the same chords. Why does it happen? How can we disengage the result of the mitral valve regurgitation, open or minimally invasively, from the skill of the surgeon and from the individual decision? Equally so for Barlow's. How can we lower the threshold for a proper repair and repeat it excellently? I developed 12 new techniques that were published in the European Journal last year, back-to-back in 2 papers, and I gave them names that easy for the surgeons to remember. I'm not going to go to all 12 of them. The Roman arch is the most popular. I'll show you the animation. It makes this standardized. You move with a single forward stitch, and it takes away the guessing, no guesswork. I can show you the animation right now in the interest of time. Look at this. P2 prolapse or A2 prolapse. Enter the anterior papillary muscle, or do it from the posterior side. You can start from there. Up into the prolapse, on the margin of the leaflet, in and out 2-3 times, and come out in the posterior papillary muscle. Do the same with the second needle, and you're done. You can then do your test, do whatever you want, put in your ring, and after the saline test, you can tie down this Gore-Tex suture. The Roman arch is the most popular in the world right now. It's been adopted from the United States all the way to Australia, from many countries. Thomas is collecting the data. And I'm glad to say, of course, proud for us, even in Paris, the birthplace of the Carpentier techniques, they started using these techniques here. So I'll show you the Minotaurus now. I call it Minotaurus because it looks like the horns of the Minotaurus. Will take care of your Barlow's. Please try it with love, share your experience, and I'll be happy to work with you on that. Minotaurus, it takes care of the disjunction of the commissure, it reduces the commissure, it goes in with, the difference to the former technique is that you enter in the commissure, down the papillary muscle, up to the prolapse, down to the posterior papillary muscle, and out in the other commissure. It's a straightforward 5-minute stitch. You don't spend an hour guessing and putting in 20 chords and still unhappy with your Barlow's. And it happened to me, and it happens to everybody, and we're still unhappy with the Barlow's result. So we developed a new endoscopic retractor which doesn't penetrate the chest. This is a Roman arch from the operation theater. You see the huge prolapse here, all endoscopic. Travel along the posterior leaflet, the prolapse area, same with the second Gore-Tex needle. You see along the margin of the prolapse, 2-3 times, you don't need more. Do your final adjustments with a hook. Put in your ring, do your saline test. And you're done. You tie on the papillary muscle and cut it off. This is the result. It takes 10 minutes, 0 mitral valve regurgitation. No guessing, where should I put the individual cord, here or there? Where on the margin? Which papillary muscle? How many cords? Single or loops? This is guesswork. So, of course, you use your experience, but this is so much more standardized and easy. And the same with the Minotaurus technique. Here is a Barlow's. Here is a Minotaurus technique again. And very expedited images from the operation theater. Go in the commissure, papillary muscle, leaflet, papillary muscle, the other commissure. You can do it forehand from the other side. Long story short, takes care of your Barlow's. You may need to do one in the anterior and one in the posterior leaflet. You may need to still close a cleft. That's fine, but it's such a simplicity and standardization of the procedures because you follow a pattern. You don't have to think and guess. I'll be happy to show you many videos. I don't need to do that. Now, where do we learn minimal invasive cardiac surgery, mitral valve surgery? This is how we used to learn before. Now we have Professor YouTube. You can visit our workshops and courses. We have an amazing simulation center in Singapore and aiming to reestablish it in Athens. Webinars, a lot of online resources, simulations here as you see. These are digital devices for cardiologists and heart surgeons. I won't miss the opportunity to show you 2 novel books. This is the book I wrote with Taylor and Francis, New York, London, where you can see and scan with your phone as you read along to see how the procedure is done using QR codes. as you see here. Another book by Dr. Zacharias in the UK, an excellent minimal invasive and endoscopic surgeon as well. With that, you'll be fortunate to know that I came to the end of my presentation and happy to take any questions.
Thanks very much, Theo, for your, I would say, even entertaining lecture. Do we have any questions?
Well, I have a comment. So they say that, you know, as interventional cardiologists, we try to mimic what surgeons are doing, but this we cannot do definitely. So, Femi, what's your take on this presentation?
Very nice presentation, Theo. Thanks for sharing. I have one question about the technique that you, innovative technique that you described about the Barlow situation with the continuous suture. How durable that repair is long-term? Do you have long-term results?
The simple answer is, of course, not, because when we discuss1 year, 3 years, 5 years, and so forth. So it's, of course, part of the validation process that needs to be done. But the initial results are very, very promising, and it delivers the surgeons, obviously, around the world, from many countries, from all this guessing. And mechanically, if I may say that, Temi, mechanically, to me at least, it makes more sense compared to the individual cords, because those calcify, they fail, they tear, whereas the arch can never tear, because, as you see, I was inspired by Anthony Gaudí, the inverse parametric tests. The tension is distributed along the entire leaflet, not punctually. Yeah.
So another question. So if someone, you know, a young surgeon is interested in doing thoracoscopic, minimally invasive surgery, what's the learning curve, and what is the volume load that it has to have? He has to have in order to maintain the skills. So
wonderful question, and I think, Yanni, you will agree that it goes the same for heart surgeon as well as for interventional cardiologists. A few factors play a role here, not only the volume. First of all, let's break some myths and taboos. The notion that a surgeon has to go to, you name it, great programs, Leipzig, Aalst, or United States, stay there for 2 years and learn minimal invasive is not true. If you have a good proctor, a good proctorship, and you proceed good patient selection with control cases, then you really need just a few cases to transfer. A simple, let's say, mitral valve replacement from the median sternotomy to the side. An experienced surgeon, like many surgeons here in the audience, you'd be surprised to know how simple it is to transit. I've taught enough surgeons in Asia who had some experience with open mitral valve surgery and transited to minimal invasive within 5 cases under structured proctorships. And then the last thing I would like to say, it depends on the individual factor. For me, there are 3 types of surgeon: the brainy, the manual one, and the chi, the solar plexus one. We are all combinations of all 3 elements. In my department back in Singapore, I had excellent brainy surgeons. They read the case notes and discuss in the heart team and blah, 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 and think about it, and restitch the proximal anastomosis twice. And this is the brainy surgeon. He has a different learning curve. The manual surgeon, it's a beauty to watch. I have such surgeons as well, Dr. Vitali, my aortic surgeon, for example. So he's painting. I call him Picasso. It's a beauty to watch his hands. And then we have the chi, the solar plexus surgeon, or cardiologist, see one, do one, teach one. He just have it in his manual brain axis. So I've taught all kinds of surgeons, and all of us are a bit like 20% like this, 60% like this, 20% like that. So the learning curve, in reality, if you select cases well and you communicate without ego, it's very, very small.
Okay, good. Dr. Pattakos.
Congratulations, Dr. Kofidis, Professor Kofidis, and we're very happy and lucky to have you in Greece. I think in answering Dr. Iakovou's question, if I can give my own viewpoint as one of the younger surgeons, and the audience and in the country. I think there's two different learning curves that are going on. The first one is, how do you do a mitral valve repair? And the second one is the minimally invasive approach. So there's a learning curve connected with each part of it. And there are some surgeons who learned how to do mitral repair through sternotomy, and then they had a learning curve for minimally invasive. And there is a younger generation, such as myself, who essentially almost from the get-go have been looking at this from a minimally invasive approach. But what has made it, I think, more difficult to be adopted worldwide is the fact that some mitral repairs are quite difficult and some minimally invasive approaches are quite difficult. So if you get a Barlow's in a patient with a bad body habitus, it can be a nightmare for the most experienced of surgeons. So I think what Dr. Kofidis said is that especially for the younger generation or someone starting out, you get a P2 prolapse in someone with a good body habitus, and you get an experienced proctor, and the learning curve is less. But I think there is a number, in the literature of around 20 or 30 cases that if you're not doing 20 or 30 mitral cases, and that's a relatively small number, but the average surgeon in the United States does 6 mitral operations, not repairs, 6 mitral operations per year. So if you don't have 20 or 30, it's very hard to, keep your numbers up. It's just like, doing a left main PCI for the interventional cardiologist.
Yes, exactly. So I think we will have to leave it there. Thank you. So there are situations that the valve pathology is too extensive, and Dr. Chamogeorgakis